and the School of Nursing for USP Ribeirão Preto, and on Facebook page for Cofen. I like nursing. Welcome, all of you. This is our second meeting, which is part of the cycle of international presentations on advanced practice nursing promoted by PAHO Brazil, the National Federal Nursing Council, and the Collaborative Center for Nursing Development in the University of São Paulo, Ribeirão Preto. The objective of this event is to
internacionais visando subsidiar
aiming to subsidize the discussion on the implementation of the advanced practice nursing in Brazil. To kick off our event, I pass the word to Dr. Monica Padilla, who is the coordinator of the Technical Unit of Human Capacities for Health and the Health Services for PAHO Brazil. Welcome, Dr. Monica. Thank you so much. Good morning, all of you. I would like to welcome all of you to this meeting, which is a part of our discussion cycle, working on the importance of the positioning of the nursing profession and the management, politics, and the formation of the health system all around the world, but mainly in Brazil. We have been working in a collaborative work, which is intersectorial and interinstitutional, and an alliance to be able to discuss these aspects that have regulations and determinations which are important to be worked jointly by the strategic stakeholders in our health system. The National Council of Nursing, the Collaborative Center of the University of São Paulo in Ribeirão Preto, in the Ministry of Health, the Ministry of Education, and so all other institutions have been working with us thinking on what would be the best strategy and what means the expansion of the practice of scope of advanced practice nursing in systems such as SUS. Certainly, we have to incorporate successful experience in the lessons learned from other countries, feeding our reflections, and this will enable us to define a strategy which is appropriate to the country, but which will enable us to globally. So this meeting allows us to exchange international experiences, and we are very happy to be able to participate together in this scientific activity, which gives the basis to the policies that the country needs so much, reinforcing the importance of nursing as the majority category. And during the pandemics, we could learn a lot, but always before the pandemics, we already had a important significance. And we need to be discussing and working to find an innovative proposal allowing us to point consistently to the Unified Health System, SUS, in Brazil, which is one of the greatest of the world, to be able to advance in quality with this experience. So I welcome, on behalf of PAHO and our support, to be working collectively in the production of knowledge and also in the proposal of the policies that are so welcome all of you, and we are going to continue the work. Monica, thank you for the opportunity. Thank you, Dr. Monica. At this moment, I pass the word to Dr. Elizabeth Pimenta, the coordinator of the Advanced Practice Nursing in Cofen, and this act representing Dr. Betânia Maria dos Santos, President of Cofen. Welcome, Dr. Elizabeth. Good afternoon all of you, Dr. Monica Padilla, Monica Durães, Professor Maria Helena, Professor Pedro Palha from the Collaborating Center. Our guest, Denise Bryant, and Cofen is here, very proud to be taking this other initiative that we started back there in 2016 with Dr. Monica Padilla, with Dr. Nadia, and back then Nadia was the vice president of Cofen, and always a person who goes beyond her political time and term, together with PAHO and now with the Collaborating Center. We have made concrete our actions that we planned in this series of meetings about advanced practice nursing in countries in Europe, North America, and a possibility to discuss the implementation, and also the formation to the advanced practice nursing. In our human capacity unit has also the support from Paulo. So I am here I know this huge responsibility that we have with these political partners to bring this highly qualified discussion with the stakeholders that represent the APN in their countries, in their universities. And Dr. Nadia has always told us that while the mission of Cofen, this topic will be very important in the discussions with the Ministry of Health, as Dr. Monica has already announced, the Ministry of Education, and our own institution, the Federal Council of Nursing, such as a regulatory agency, institution of the profession. So we're very glad here to have this very informative afternoon, and I hope that we have lots of productive contributions of our partners, nurses, and professors, and the staff who is here with us through PAHOs and Cofen channels. And I also would like to remember the lab, the innovation lab that we have, the tender for the second innovation lab that is open, the public tender, which is open for the Brazilian nursing to present their experiences that are innovative, to bring the recognition, and not only visibility but recognition, social recognition, to the practice, to the nursing practice with this public tender. And I would like to, our listeners, send your work, send your experiences. The Brazilian nursing needs to know more and hear more about the good stories, the good things, the important and strong points that we as a professional category have been developing in the unified health system in Brazil, SUS. So Monica Durans, Dr. Monica, thank you so much. Welcome, Dr. Denise, and I hope that we have a very wealthy and productive afternoon with lots of contributions and clarifications. Thank you so much, Dr. Elizabeth. And now we'd like to invite Dr. Maria Helena Maziali, Director of the Nursing School of Ribeirão Preto, USP, for her opening words. Thank you very much, Dr. Monica. Good afternoon, everyone. Those of you that are here with us in this opening panel, and those of you that are also with us in the digital virtual platforms. We know that we have lots of people connected. In the last cycle, we had more than 1,200 people, at least until the day that I could see. So I know lots of people are interested in connecting to this idea to unite with us with in this effort to reach this goal and target and challenge. And I believe that was set for us some years ago, as Elizabeth already mentioned, and that we need now to unite our efforts for this ideal and with this challenge. And each of us, we have a parcel of contribution. And besides the political issues here represented by Dr. Monica Padilla, who is a crazy, wonderful incentivator. I'd say usually that Monica has a lot of medals on her. Nurse of the year, of the previous year, and of the decade on her. So she brought to us this beautiful energy, this wonderful energy, to work on those issues and to improve the practice and improving the formation and the capacity building. So this incentives us and encourages. And I would like to thank you on behalf of the Brazilian nursing. Thank you very much, Dr. Monica, for this energy and this effort, and that moves us and encourages us to move on. Elizabeth and Cofen, we work with the School of Nursing in Ribeirão Preto as well as a collaborating center. Well, for 32 years, PAHO is a collaborative center. So we have lots of challenges, and we've been working with lots of people who have coordinated and directed our school and contributed with lots of reflections, lots of ideas, and lots of activities. And Cofen has always been together with us in this, so it's just a great satisfaction to be here representing our school now as a director. And here I would like to thank Dr. Carla Ventura, who is the director of our collaborative center, who did not measure efforts together with the commission of our school, who is organizing this event. internally Dr. Professor Pedro Palha, who is making this coordination. And what we could see in the previous cycle was a very successful experience in Chile, and today we're going to be toasted and greeted with a wonderful, successful experience from Canada. And we'd like deeply to thank Dr. Denise Bryant to be here available with us to share with us all of this knowledge, all of this experience that will be very rich and wealthy, so we could together be advancing in the planning of the strategies in the field of practice and an implementation of innovative proposal of qualification, capacity building of our nurses, and the actions and the practices, improving the assistance for the community. So it's a great satisfaction to be here, and I wish all of you a great afternoon, and that we could be leaving after this event with even more energy and more to continue in this mission. Thank you very much, and a great afternoon, everyone. Thank you, Dr. Maria Helena. We would like to thank the participation of our important partners that compose the discussion committees of the Advanced Nursing, Practice Nursing in the Brazilian Society of Nursing, Education and Nursing, CONASEMS, which is the National Council of Municipal Secretaries of Health, the National Council of State Secretariats of Health, to the Ministry of Health, Ministry of Education, University of Brasilia, among other important partners in this activity, which is so important in the field of nursing. So continuing, we'd like to thank Dr. Denise Bryant to be here and accepting the invitation to be here and sharing the experience and knowledge on advanced practice nursing in Canada. And now I pass the work to Professor Dr. Manuel Miranda, representative of Cofen, member of the Commission of Advanced Practice Nursing of Cofen, to introduce our dear guest and to moderate the panel. Welcome, everyone. Thank you so much, Monica. Good afternoon, everyone. Hello. Thank you once again for the steering committee for this cycle of lectures and presentation that surely will contribute a lot to help us think on the advanced practice roles in our country. So I think it's just important to clarify just some aspects that we are here with being broadcasted in 2 languages. We have the broadcast on YouTube for channels in English, and we also have Facebook for Cofen broadcasting this presentation for Portuguese. So I'd like now to say that I have the honor to invite our keynote speaker for today, and also to introduce our speaker, Professor Dr. Denise Bryant-Lukosius. She is a professor, associate professor of the School of Nursing in McMaster University, Canada. She's an associate member of the Department of Oncology, also in McMaster University. She's the vice director of the Canadian Centre of Research in Advanced Practice Nursing. She's the director of the Canadian Centre of Excellence in Nursing, Advanced Practice Nursing in Oncology. She's a nurse, master, doctor. She has a production, which is an vast production, which is very significant in the APN field, being an international reference. Personally, I am very happy and honored to have Professor Denise Bryant here with us. I'm glad to be here because I admire your production so much, Professor. So it's really a unique, special moment that I waited so much to be here together with such a researcher that I admire so much. So thank you so much. I would like to invite you to start your presentation. Please feel free at home to start your presentation, take your time. And right afterwards, we're going to have a Q&A session where we are going to be able to debate and dialogue with our public and audience, and also exchange some ideas, suggestions, because surely that's going to be, your presentation is going to be motivating us so much. So thank you so much for accepting our invitation to be here with us, and thank you for this experience.
Thank you very much, Manuel. It's my pleasure really to be here today, and I want to thank the Collaborating Center and the School of Nursing in São Paulo, and also PAHO and the Brazilian Federal Council of Nursing for inviting me to be here today. I have to say, listening to the introductions, it's very exciting to see the level of intersectoral collaboration that's happening across Brazil to implement advanced practice nursing roles. So we'll see if my slides go. There we go. So today I'm going to describe the current state of advanced practice nursing roles in Canada and discuss the barriers and facilitators to APN role implementation, and then conclude by examining needs in Canada to further integrate advanced practice roles into our healthcare system. Geographically, the geography of Canada plays a large role in how healthcare services are organized and delivered in Canada. And as you can see in the map there, Canada is a large country. It's the second largest country in the world, but has a small population base of just 35 million people who live across 13 provinces and territories. People live predominantly in southern urban areas of the country that align at the border of the United States. But about 20% of Canadians live in rural or northern remote communities where there are few healthcare providers and services. And often registered nurses or nurse practitioners may be the only healthcare provider in those communities. Canada does have a universal healthcare system. Through provincial and federal tax dollars, Canadians have access to primary care that is still mostly delivered by family physicians in private practice. They also have access to coverage for hospital services and some outpatient and home care services in their provinces. But provincial healthcare coverage is not comprehensive, and people still need to pay out of pocket for considerable healthcare services in outpatient settings, in rehabilitation care, and also drugs and equipment. Legislation at both the federal and provincial territorial levels impacts on healthcare and thus the implementation of advanced practice nursing roles. But increasingly, we're finding that the federal government has become less involved in healthcare policy, regulatory issues, and funding. The provinces and territories are responsible for the organization and delivery of healthcare services in their jurisdiction. And as a result, different provincial regulations and policies and healthcare delivery models, and also priorities within the healthcare systems impact on the implementation of advanced practice nursing roles. Just to put advanced practice nursing into context of the rest of the healthcare system, nurses represent the largest health profession group in Canada. And as you can see there, for every 1,000 Canadians, there are, every 100,000 Canadians, there are 780 registered nurses and 190 physicians, and then much smaller numbers of other healthcare providers, such as physiotherapists and midwives. There are several types of regulated nursing roles, and you can see there in 2020, we had over 130,000 licensed practical nurses who are educated at the diploma level, and over 300,000 registered nurses who have at a minimum a baccalaureate degree. There are 5 provinces and territories who have licensed psychiatric registered nurses. And then you can see that there are over 6,600 master's prepared nurse practitioners in Canada. Across all nursing and other health profession groups, nurse practitioners have had the greatest increase in numbers, growing by 8% in each of the last 3 years. But overall, Canada expects by this time next year in 2022 that there will be a shortfall of almost 60,000 full-time registered nurses. There is a national framework for advanced practice nursing that was established in 2000, and this framework has been revised over the years. So you can see that this is now the third edition, published in 2019. And advanced practice nurse defined as an umbrella term for registered nurses and nurse practitioners who integrate graduate nursing educational preparation with in-depth specialized clinical knowledge and expertise in complex decision-making to meet the health needs of individuals, families, groups, communities, and populations. The Canadian Nurses Association has guided the development of this document over the years, and the national framework has been really important for gaining consensus across the country about what advanced practice nursing is and increasing understanding of the role. There are two types of advanced practice roles recognized in Canada: the clinical nurse specialist and the nurse practitioner. Both roles were introduced in the 1960s and 70s, but as you can see, it's been a long and windy road to introduce these roles, and it was really not until 2010 that the roles have been established in all 13 provinces and territories. There's also been fluctuating demand for APN roles over the years based on healthcare policies and also politics, physician supply, and the economy. There's also a national framework outlining specific competencies for the clinical nurse specialist, who's defined as a registered nurse who holds a graduate degree in nursing and has a high level of expertise in a clinical specialty. The areas of specialization may focus on expertise for a specific patient population or practice setting, or a disease or subspecialty, or a type of care such as palliative care, or a type of health problem such as pain. The aim of the CNS role is to improve client, population, and health system outcomes by integrating knowledge, skills, and expertise in clinical care, research, leadership, consultation, education, and collaboration. The CNS role was introduced in the 1970s to address patient, nursing practice, and organization needs arising from the increasing level of specialization and also the complexity of healthcare, especially in hospitals. Clinical nurse specialists have the same scope of practice as a registered nurse. They're designed to improve access to integrated and coordinated care through innovative nursing interventions. And they lead and act as clinicians, researchers, consultants, and educators to address complex healthcare issues at three levels: the level of the patient, nurses and other health providers, and organizations and health systems. There's also a separate national competency framework for nurse practitioners, who are defined as autonomous health professionals with advanced education who provide essential health services grounded in professional, ethical, and legal standards. In addition to core competencies necessary for advanced practice related to clinical practice, leadership, research, consultation, and collaboration, there are also specific core competencies for nurse practitioners related to professional role responsibility and accountability, health assessment and diagnosis, therapeutic management, and health promotion and prevention of illness and injury. Formalized NP roles evolved from outpost nurses who were working in expanded roles in rural, northern, and remote communities. And these roles were really introduced to increase access to care. And then in the 1960s, the federal government provided short education programs to increase the knowledge and skills of these outpost nurses. but this education was really found to be inadequate for these nurses who were often working alone in very isolated communities with limited support. In the 1970s at McMaster University, where I'm from, we launched the first primary healthcare nurse practitioner program in Canada. And from that, the first landmark Burlington randomized control trial of nurse practitioners in primary healthcare was conducted. And despite study results demonstrating nurse practitioner safety and effectiveness, the lack of government funding to recruit and hire nurse practitioners once they had graduated led to the closure of the program. And it wasn't until the mid-1990s that the program was reopened following provincial funding for nurse practitioner education and funding for positions in primary healthcare. We now have 4 types of NP roles in Canada: family all ages or primary healthcare, nurse practitioner adult, nurse practitioner pediatric, which also includes neonatal NPs, and nurse practitioners in anesthesia care. The NP role in anesthesia care was launched in Ontario in the early 2000s, but really the role did not survive because of lack of government funding for positions for nurse practitioners once they graduated, and also physician resistance to the role. So really, the role went nowhere, and the program no longer exists in Ontario. But the province of BC is just in the midst of introducing this role. And so it will be interesting to see if they have more success in that province than we did in Ontario. Nurse practitioner education is at the master's level, but initially NPs were educated at the baccalaureate level, and we still have some baccalaureate prepared nurse practitioners practicing today. Nurse practitioners can autonomously diagnose, order and interpret diagnostic tests, prescribe pharmaceuticals, and perform procedures. And they care for individuals, families, and communities in a variety of areas related to population health and health promotion, disease prevention, illness management, and supportive, curative, rehabilitative, and palliative care. So there can be some overlap between clinical nurse specialists and nurse practitioner roles, particularly in acute care settings, which can make it difficult for others to understand these roles. And this diagram has been found to be helpful for distinguishing role differences. So in this diagram, so if you just look at the top of the diagram here, APN roles are viewed as occurring over a continuum, with CNSs on one side of the continuum and nurse practitioners on the other side. Both roles must integrate domains related to clinical practice, as well as domains related to professional development, organizational leadership, research, and education. However, the emphasis or focus of each of these activities varies between the clinical nurse specialist and nurse practitioner. CNSs tend to have more role responsibilities in the integrated role domains related to leadership, research, and education, and have fewer responsibilities in the clinical domain. In contrast, nurse practitioners tend to have greater responsibility in the clinical domain and spend less time in other domains related to nursing practice, research, and education. Another difference is that nurse practitioners have an expanded scope of practice that is above that of the registered nurse. And for that reason, this requires an extended license for practice. The wavy line here in the middle illustrates the fluidity and the dynamic nature of these roles. So the balance of clinical and non-clinical activities varies for each individual clinical nurse specialist or nurse practitioner in response to changing patient and organizational needs. On balance, nurse practitioners spend about 80% of their time in clinical activities and 20% in the other. But again, it fluctuates quite a bit. Thus, there is high variability in how CNS and NP roles are operationalized. So even within the same organization, CNSs and NPs can function differently depending on the needs of the programs that they're working in. And so while this flexibility is a strength, it also contributes to role confusion and makes it difficult sometimes for stakeholders to understand these roles. The results of a national study we conducted in 2018 provide support for this model comparing CNS and NP roles. In this study, we compared time spent implementing advanced practice nursing role activities among nurse practitioners, clinical nurse specialists, and baccalaureate prepared specialized registered nurses in non-advanced roles. And I know this is a busy slide, but I'm going to ask you just to focus first on the direct care area here. And you can see that all three roles, the clinical nurse specialist, nurse practitioner, and specialized registered nurse, were all actively involved in the direct delivery of clinical care. But nurse practitioners, the red line here, had significantly higher mean scores in terms of time spent compared to both specialized nurses and clinical nurse specialists. In contrast, clinical nurse specialists, which is the blue bar, they were more involved to some extent in all other non-clinical role domains. So you can see here CNSs spending much more time in all other domains of advanced practice compared to both nurse practitioners and specialized nurses. And nurse practitioners were also more likely to be involved in research and leadership activities compared to specialized nurses. So to tease out, well, what was different about what they were doing in terms of direct comprehensive care? We found that nurse practitioners spent more time in 12 out of 15 items compared to both CNSs and NPs, predominantly related to medical aspects of care. So assessment, diagnosing, ordering diagnostic tests and procedures, communicating the plan of care, and patient education. While CNSs spent more time in 3 out of 15 items compared to specialized nurses related to more complex aspects of care, including ethical decision-making, coordinating interdisciplinary care, and collaborating with other services. And CNSs also spent more time compared to specialized nurses and nurse practitioners acting as a consultant to improve patient care. In addition, specialized nurses spent more time than clinical nurse specialists in 3 out of 15 items. And these items really related to routine clinical aspects of care, such as performing patient assessments or care procedures and documenting in the patient chart. But there were no differences between clinical nurse specialists and specialized nurses related to other clinical activities associated with psychosocial assessments, planning and coordinating care, evaluating care, and providing patient education. And neither of these roles were involved in the delivery of medical activities. In terms of education, clinical nurse specialists spent more time than nurse practitioners and specialized nurses in 5 out of 6 items. And nurse practitioners, this was an interesting finding, nurse practitioners spent more time than CNSs and specialized nurses providing patient and family education. Related to the domains of supportive systems, research, and leadership, clinical nurse specialists spent more time than nurse practitioners and specialized nurses for all items in these domains. But nurse practitioners also spent more time than specialized nurses in implementing projects or providing presentations related to supportive systems, They were also more involved than specialized nurses related to 4 out of 6 research items and in all items related to professional leadership. A national study that we conducted in 2010 identified several barriers to the implementation of clinical nurse specialist and nurse practitioner roles. And these barriers related to the ad hoc development and implementation of the roles, and also the focus on substitutive models, especially for nurse practitioners. So nurse practitioners as a replacement for physicians, rather than a focus on the complementary nature or the addition of the roles to improve healthcare delivery and outcomes. A fragmented approach to the integration was also a barrier. Lack of role clarity and role awareness amongst stakeholders. We also found a mismatch between education and practice. Barriers also related to restrictions on scope of practice and lack of protected role titling. And within practice settings, consistent failure to address barriers within the environment that advanced practice nurses worked was also a barrier. We found there were intra and interprofessional tensions and also issues related to the lack of funding or reimbursement policies, and also barriers related to not producing or not using relevant evidence to support role implementation. We also identified common themes about factors that facilitated CNS and NP role integration, and these focused on using systematic and patient-focused approaches to role planning, early stakeholder engagement to design and plan the implementation of APN roles as a way of promoting stakeholder understanding and role acceptance, having clearly defined roles, and promoting public and healthcare provider awareness of the roles. In 2018, we did an analysis to see, well, what kind of progress had been made since our original study in 2010. And we noticed that there had been substantive progress in those convening 8 years, especially related to the integration of nurse practitioners. That overall, the necessary changes to health policies to support the full integration of both CNSs and NPs was a very slow and incremental process. Pan-Canadian approaches, such as the development of national frameworks and competency documents, have helped to strengthen stakeholder understanding and reduce variability in practice standards and competencies, and also education, and have helped to facilitate labor mobility. But again, this is predominantly for nurse practitioner roles. And unfortunately, we can continue to see underutilization of both CNS and NPs in the healthcare system. Nationally, the Canadian Association of University Schools of Nursing has established a national framework for nursing education that delineates the differences in expected outcomes between baccalaureate, master's, and PhD nursing education programs related to knowledge, research, methodologies, critical inquiry and evidence, nursing practice, communication and collaboration, professionalism, and leadership. In addition, it also clarifies expectations of master's programs aimed to produce nurses who work in advanced roles related to clinical practice. So that would focus on CNSs and NPs, compared to those working in advanced roles, but in non-clinical areas related to education, leadership and management, or research. There's very limited access to clinical nurse specialist specific education or specialty focused graduate nursing education across Canada. The only exception to this is in the French-speaking province of Quebec that has CNS programs for infection control. And in addition to primary healthcare, has specialty-based NP programs in neonatal care, nephrology, cardiology, and mental health. In Ontario, we've just recently seen the introduction of a master's program in mental health, but it's not specific to CNSs or NPs. We currently have a shortage of neonatal NPs due to cuts in provincial programs across the country. And we also have difficulty in recruiting NPs to highly specialized areas of practice that have growing demands for care, such as hematology, oncology. Canada simply lacks the sufficient population base to have a critical mass of students that would warrant mounting the costs associated with very varied specialty-based programs. We also have a shortage of faculty with the expertise to teach in specialty-based programs. So most often, programs are often offered at a generic level, with students left to carve out clinical experiences both during and after the program to gain specialty expertise. And although a graduate degree is recommended, there are no mandatory educational requirements to be a clinical nurse specialist in Canada. And thus there's limited incentive for universities to offer CNS-specific programs. And the lack of CNS education has had a negative impact on role clarity and the ability to socialize nursing students to become clinical nurse specialists, and also has an impact on the long-term sustainability of the role. To address challenges in recruiting nurse practitioners with specialized expertise, governments and organizations are needing to develop new alternative training strategies. For example, there have been unprecedented increases in the demands for hematology, oncology care due to advances in treatment, including immunotherapies, targeted cell therapies, and stem cell transplant. So at the Juravinski Hospital and Cancer Center, where I'm cross-appointed as a clinician scientist, we've received funding to develop a nurse practitioner fellowship program in complex malignant hematology to facilitate the recruitment and retention of nurse practitioners in this area. In contrast to clinical nurse specialists, there has been tremendous progress to expand the number of nurse practitioner education programs. They now exist in all 10 provinces for primary health care and or acute care adult or pediatric programs. There have been also efforts to harmonize standards for nurse practitioner education across the country. And one example is this national framework established by the Canadian Association of Schools of Nursing, outlining the principles for guiding nurse practitioner education programs. There are no specific regulatory or credentialing requirements for clinical nurse specialists. They have the same regulations and scope of practice as baccalaureate prepared registered nurses. And the lack of regulatory policies specific to the CNS role to mandate credentialing requirements and to protect role title has made it difficult for us to accurately assess employment trends. For example, in our 2018 National APN Role Delineation Study, only 61% of self-identified clinical nurse specialists had a job title of clinical nurse specialist. They reported over 13 categories of job titles to describe their roles. In addition, not all self-identified CNSs met the requirements for advanced practice. So only 73% were master's prepared, and only 70% were working in a clinical role as a major feature of advanced practice. Due to the lack of registries to identify master's prepared CNSs in each province and territory, we really don't know how many CNSs exist in Canada. But some data suggests that between 2000 and 2016, the numbers of CNSs declined. However, we have also found reports of higher CNS deployment with actual expansion of the roles beyond hospital and acute care settings to community services, hospitals, and long-term care. Over the last 10 years, but there's been significant progress in NP role regulation. Almost all legislative and regulatory barriers to NP practice have been eliminated at both the federal and provincial levels. We see also seeing increasing consistency of NP scope of practice across all jurisdictions. They are fully autonomous roles related to diagnosing and ordering diagnostic tests, performing procedures, prescribing medications, including controlled drugs and substances, and admitting and discharging patients from hospital. And while consultation and collaboration are desirable, physician supervision of NPs is not required. About 3 years ago, medical assistance in dying or MAID became legal in Canada, and nurse practitioners are authorized to assess patients for their eligibility for MAID, and they are also authorized to order and perform the procedure. Any remaining barriers to full NP scope of practice predominantly exist within healthcare organizations where policies and practices have not kept pace with the regulatory changes. Each province and territory has its own regulatory nursing board governing the requirements for nurse practitioner practice. And these requirements vary across the jurisdictions, which can limit NP mobility from province to province. In general, though, each province and territory requires registered nurses to successfully complete an approved master's or postmaster's diploma program specific to NPs and pass an NP-specific exam determined by their province. In most provinces, for primary healthcare nurse practitioners, they write the Canadian Nurse Practitioner exam. For NP adult and NP pediatric, they write American State Board exams. And 2 provinces require NP graduates to pass the objective structured clinical exam. And then in Quebec, the French-speaking province, it's a totally different picture. They have different exams, different practice streams, and totally different requirements from the rest of the country. Once NPs are licensed to practice, to maintain their registration, there is a rigorous process that they must meet to demonstrate ongoing clinical competency by obtaining a minimum number of clinical hours and participating in continuing education, and also conducting peer reviews, chart audits, and case studies about their practice. In 2015, a practice pattern study found that nurse practitioners implemented the same core competencies across all 3 streams, so family, all ages, or primary healthcare, and NP adult and pediatric, regardless of the education program completed or where the NP practiced. And this finding led to a project to harmonize NP competencies and regulatory requirements. Excuse me. And this initiative, once it's approved, will result in one set entry to practice set of competencies for NPs for just one registration category instead of 3, and it will be at the generalist level. So how competency for specialty-based practice will occur has not yet been determined, so that is a big question mark. And once approved, this initiative is going to have significant impact on our existing NP education programs. CNSs and NPs are mostly salaried employees. Unlike in the United States, they cannot bill fee-for-service to government or other healthcare insurance plans. And lack of government funding for CNSs and NPs is a major barrier to full health systems integration of the roles. It means that organizations must allocate funds from their existing and shrinking budgets to recruit and retain CNSs and NPs. Where there has been targeted funding for new nurse practitioner positions, this has led to expansion of the roles in primary care, long-term care, and in hematology, oncology. NP wages vary by province, but on average, they range from $90,000 to $120,000 per year, which is somewhat more than what registered nurses make, depending on their province, and also type of role and years of experience. Nurse practitioner wages are also significantly less than family physicians who may perform similar work. And in some provinces, nurse practitioner wages also differ by practice setting. So for example, in Ontario, nurse practitioners in hospitals make more money than those working in community and primary care settings. And as a result, many primary healthcare NPs are attracted to work in acute care settings. There is research that from Canada and from other countries that physician fee-for-service models are a barrier to the optimal implementation of nurse practitioner roles. And this is because it sets up some competition, potentially for patients, and that may negatively impact on physician salaries. So wherever possible, physician reimbursement models should minimize the impact of NPs on physician salaries and also support physician collaboration with NPs. There have been few examples of provincial or territorial funding for CNSs, but in 2005, sorry, I'm just going to have another drink of water here. In 2005, the federal government, which is responsible for Indigenous health, hired a large number of clinical nurse specialists for over 600 Indigenous communities across the country. And these roles continue today, and they're designed to address unmet population health needs, to improve the recruitment and retention of nurses, and improve the quality of nursing care for high-risk populations related to maternal child health, mental health and addictions, chronic disease management, and diabetes. But we have seen dramatic expansion of NPs in primary healthcare due to provincial policy priorities for primary healthcare reform. And this has led to increased funding for education programs and also new positions. Between 2006 and 2010, the provided $10 million for the Canadian Nurse Practitioner Initiative. And this funding was to support NP development. It included funding for NP-focused research, public awareness programs, the development of the Pan-Canadian competencies, and triggered new education programs and research and development of NP practice. It also led to the development of new tools to support NP roles. And over time, policy priorities have also resulted in new funding to expand these positions. Despite the new funding and the emphasis that's been placed on nurse practitioner roles in Canada, we do see differences in NP deployment and suboptimal utilization of the roles across the country. So some of these differences relate to variability in healthcare priorities, but also the extent of physician pushback to the roles, especially in primary care in different jurisdictions. So you can see here that 60% of all nurse practitioners in Canada work in one province, Ontario. Now, this is to some extent because Ontario has the largest population base requiring NPs, but other provinces have also been slower to adopt NP roles. The majority of NPs are also primary healthcare NPs working outside of hospitals. And in some provinces, NPs from primary healthcare NP programs are working in hospitals in specialized areas of practice because there is lack of funding for NP roles in the community. NPs do work in a variety of healthcare settings, including hospital inpatient and outpatient settings, community settings, hospice, long-term care, and more recently, we've seen their introduction to provide primary healthcare in community facilities. Excuse me. So where do NPs land in terms of the nursing workforce? Well, even with all the progress we've made, they still only make up about 1.5% of our nursing workforce. And this is a small proportion compared to the United States, where NPs make up 6.5% of their nursing workforce. That being said, primary healthcare NPs have been described as the backbone of rural and remote healthcare in Canada. And they're often introduced in urban settings to address primary healthcare needs for hard to reach and underserved communities that are impacted by the social determinants of health. There are some studies demonstrating the positive impact of nurse practitioners in primary healthcare. In this study conducted across 137 primary care practices that had different funding and delivery models, the only consistent predictor of high quality chronic disease management care was the presence of a nurse practitioner. In emergency departments, NPs have been shown to reduce patient wait times and length of stay and prevent patients from leaving before they've been seen. So predominantly in Ontario, but we're now seeing them in other provinces, family health teams are government-funded, multidisciplinary primary healthcare clinics that are traditionally led by physicians. And only physicians, especially in Ontario, were only allowed to apply for funding to start a family health team. And in one Northern Ontario region, we had over 30,000 people with no primary healthcare provider, but also unemployed or underemployed nurse practitioners. And these nurse practitioners lobbied over 3 years to the government to be allowed to apply for funding to start a family health team when no physicians in their region would apply. And ultimately, they were successful, and the first NP-led family health team was launched in 2006. And by 2017, there were 27 nurse practitioner-led family health teams providing care in underserved communities in Ontario. NP-led family health teams provide comprehensive patient-focused primary care. It's holistic care from birth to death. They focus on health promotion and disease prevention. They provide chronic disease management and support for patients with mental illness. They provide care coordination and system navigation, and they help to integrate care across community services through partnerships. The initial evaluation of the first NP-led family health team demonstrated high patient satisfaction with this model and improved access to care, shorter wait times, an increase in the number of same-day appointments, reduction in the patients' use of walk-in clinics and ED visits, and better control of medical conditions. And almost 50% of patients reported receiving lifestyle counseling with improved health behaviors and better management of their chronic health conditions. But demand for care was still high, and still about 40% of patients had difficulty getting a same-day appointment. So I'm going to make a bit of a switch now to talk about research. And from 2001 to 2011, Dr. Alba DiCenso, a professor at McMaster University, held a federally funded chair designed to increase Canada's capacity to conduct APN-related research. And I happen to be a PhD student, a postdoc fellow, and a junior researcher over the 10-year life of the chair program. And when the chair program came to an end, a core group of chair program graduates, including myself, established the Canadian Centre for Advanced Practice Nursing Research to continue this work. And I now have the privilege of being the inaugural holder of the Alba DiCenso Chair in Advanced Practice Nursing at McMaster. And I tell this story to illustrate the importance of national funding to support APN research. This work has been an important asset for APN role development in Canada. Much of the research we've conducted since 2001 has informed important provincial and national policies and practices, and informed what happens at organizational levels to optimize the use of CNS and NP roles. And we've also developed a number of tools and resources to support APN role implementation. So one of those tools is the Peppa Framework, which outlines a participatory, evidence-based, and patient-centered process for APN role development, implementation, and evaluation. And importantly, the steps of this framework include strategies to address known barriers to APN role implementation. The framework has been used in over 20 countries for introducing APN roles at different levels. So within teams or practice settings, across organizations more broadly, and also at regional, national, and international levels. It's been used by government agencies, healthcare institutions, professional associations and universities, and by advanced practice nurses, researchers, educators, policymakers, healthcare administrators, and other advanced providers. Some examples of framework application include the development of a strategic plan for introducing APN roles in Latin America and the Caribbean, the development of a family NP education program in Eswatini, introducing APN roles in Chile, and also the introduction of nurse practitioners and physician assistants in emergency departments. Users of the framework have found that it helps to identify and anticipate important steps in the role development, implementation, and evaluation process. It helps to improve team function through team member participation in role planning and decision-making. It helps to promote APN role clarity and agreement about role priorities. It helps to promote role understanding and acceptance and support for the role through stakeholder engagement. It helps to improve coordination and patient satisfaction with care by engaging patients in the role design process, and ultimately helps to minimize barriers and maximize the facilitators for effective role implementation. A knowledge translation tool we developed from one study was this toolkit to promote the effective development and implementation of APN roles in cancer care. However, the tools and resources in this toolkit are relevant to any type of role, regardless of setting or specialty area. And this toolkit is freely accessible to you and downloadable at the URL provided. One example of a tool in this toolkit is the logic model template to guide the design, implementation, and evaluation of APN roles. More recently, the Peppa framework was developed to provide more detailed guidance about how to evaluate APN roles across 3 stages of role development. A toolkit is also available to support application of the Peppa framework, including examples of structures, processes, and outcomes to consider for evaluations at each of the 3 stages for APN role development. There are also examples of evaluation questions, a template for developing an evaluation plan, and a case study demonstrating framework application across the 3 stages of role development. So in summary, the current status of advanced practice nursing in Canada really has never been better, especially for nurse practitioners, and the future is bright. However, full integration of CNS and NP roles into the Canadian healthcare system has yet to be achieved. The time is ripe for us to leverage the current focus on rebuilding our healthcare workforce and addressing the nursing shortage that's been intensified by the pandemic to optimize the use of CNS and NP roles. We also need to use more effective knowledge translation strategies to influence healthcare policy and decision-making that will increase the uptake of CNS and NP roles into the healthcare system. It will also be important to use a more systematic versus ad hoc approaches to introduce a critical mass of CNS and NPs to really impact on high need areas at local, provincial, and national levels related to primary health care, chronic disease prevention and management, aged care, mental health, and Indigenous health, and to increase access to care for underserved populations and those impacted by the social determinants of health. We're also expecting to see new needs arising and have already occurred due to the pandemic. There is a substantive systematic review evidence about the effectiveness of both CNS and NP roles. But for CNS roles in particular, given this evidence about how they can address health system needs to improve access and quality of care, we really need more concerted efforts to ensure the long-term sustainability of this role. And we're going to need to do a better job of aligning the evidence about CNS effectiveness and impact with government policy priorities for health systems improvement. And nationally, while this is essential for CNSs, we also need to establish credentialing policy priorities for specialized practice and improve access to specialty-based education for both CNS and NP roles. Finally, there's also need for contextually relevant Canadian research about CNS and NP roles. There's actually quite limited research about CNSs and NPs in Canada, in particular with needs for better evidence about their effectiveness in new models of care, for example, the increasing use of virtual care, and for patients receiving new and emerging therapies, such as precision medicine. Internationally, there's also limited evidence about the cost effectiveness of CNS and NP roles, so we need to continue to work on that. There's also limited international evidence about best practices for CNS and NP regulation or credentialing, or how to optimize recruitment and retention, and what are best models for remuneration and reimbursement. And in Canada, we also need more PhD prepared clinical nurse specialists and nurse practitioners and other nurse scientists to lead this work. And that is the conclusion of my presentation. Obrigado. Thank you for inviting me to be here today, and I look forward to having some discussion and answering any questions that you may have.
Muitíssimo obrigado, professora Denise.
Thank you so much, Professor Denise. Wonderful presentation, really inspiring, and also pleasing us because we are here discussing with the conducting group or the steering group how our perspectives to advance. So I would like to thank all the people connected with us here in different platforms, in 4 different channels where your presentation is being broadcasted. And we have already received a set of questions. Well, the first question, Dr. Denise, I will try to make a summary here, considering some areas. So it's some questions related to the formation, actions or acting, and the relation to the development of the career. So we have here several areas to explore. The first question that I would like to make, Professor, is, well, we have here in Brazil a model, a career model, and a career path, professional path, and a formation path, which is different from Canada. And lots of times we have this difficulty to comprehend the model of formation in Canada or in the USA, how this is related or similar to the Brazilian model. That's why I would like to ask you to tell us, giving some examples maybe, and thinking on the pathway, on the formation, on education, and on the perspective of a career for a nurse that just left college, just graduated as a registered nurse, concluded the course, and she wants to become an NP or a CNS. What courses should she go to or take? What are the pre-requirements normally? So, for example, is it expected of her to have a professional practice as a registered nurse before going to a specific program for the mastering? And these programs are different. Are there different phases throughout this formation process? So I would like to hear a little bit more from you in this line, please.
So that's a great question. And I think the idea about, in general, having clear delineated career paths for nursing is a strength. Canada doesn't have that model, but I think clearly articulating those pathways for nurses is really important. So that's great that Brazil already has something like that to build from. To apply to a nurse practitioner program, most programs require nurses to have at least 2 years of experience as a registered nurse. And that is because the competencies build on that of the registered nurse. So in terms of a career path, everyone starts at the sort of the level of the registered nurse. You have to meet those entry to practice competencies and have some experience before you can apply to a nurse practitioner program. Because those competencies build on that of the registered nurse. I would say that I've noticed, because I've been around for a long time, this is I think my 40th year as a registered nurse. And so I've seen the evolution of almost 2/3 of advanced practice nursing time in Canada through that 40 years. And when NP programs initially started, those who were applying to the programs were very experienced and often master's prepared clinical nurse specialists. So we had the best of our registered nurses applying for NP programs. They were often in their mid 40s or early 50s. You know, these were seasoned nurses. And I think probably they were able to take on the transition to an NP role easier because they were also experts in their areas of practice already. That is not the case now. Now we have many nurses applying after 2 years of experience. So they have less experience under their belt. They've less exposure to the world issues affecting nurses and how to navigate them. They still have a lot of, even at 2 years, your confidence and competence as a registered nurse is still developing. And so I think that's why we're seeing worldwide the need for NP transition programs from NP student into the role. And I just finished a literature review not too long ago about the international development of advanced practice nursing roles. And one of the things that struck me most about what was new in the last 3 years was the number of papers that talked about the need for transition programs, not just for NPs, but also CNSs and midwives. So lots of papers describing residency programs, internships, fellowships like what we have at the Juravinski Hospital, mentorship programs to help students transition from their education programs to implement their role in the first few years.
Muito interessante, professor.
Very, very interesting, Professor. And normally saying the courses, the master courses, they have a consensus in relation to a minimum number of hours of clinical practice along the course, being a course to prepare CNSs or a course for NPs. Is there a difference in this number of hours?
No, I think the programs are fairly standard, and don't quote me on the number of hours. I know it's well over 750 clinical hours in the NP program and maybe more. They're heavily clinically focused programs. And in Ontario, for example, our NP program is a provincial program. It involves a consortium of 6 universities. So every NP in Ontario graduates from the same program. Their diploma will be from a different university, but they all achieve the same program. It's offered a combination of online and face-to-face, with each university, each of the 6 universities, including McMaster, being responsible for specific courses. And generally what happens is the first year of the program is at the master's level at the home university. And so there can be some variability in those courses, but the second year is all of the NP courses, and everyone takes the same courses, which are predominantly focused on increasing levels of health assessment, clinical decision-making, diagnosis, prescribing, etc., in different practice settings. There is a little bit of debate, I think, among NP education programs about how much to include around the other domains of advanced practice, so related to leadership, consultation, improving nursing practice. So the non-clinical domains, research, quality improvement, evidence-based practice, how much of that should be included in programs. And, you know, it used to be, some programs are heavily research focused, where the students take both qualitative and quantitative research methods, and others less so. For sure, every program would include something around evidence-based practice and critical appraisal of the evidence as being essential. So there is a little bit of flexibility there, but overall the programs are fairly similar.
Perfeito. Professor, esses programas,
Perfect, professor. And these programs, at the end of the program, is it required the delivery of a work? For example, we have the master, the professional master's course, where the production or the delivery would be a product. We call it a product. So it could be something directly related to the practice, an app, an application, something that has a direct application to the practice, or a dissertation. The advanced practice masters there demand or require products as well?
Yeah, no. Generally, master's programs for nurse practitioners they're non-thesis based programs. They're professional clinical programs. So they are not required to do a master's thesis, and they are not required to produce a product. They do have courses, nursing theory, evidence-based practice, research courses. So I teach a course on research methods that's designed specifically for nurse practitioners and our course-based students. And the end product of that is a proposal to conduct a quality improvement research or program evaluation initiative. So some of the assignments may result in a product, but it's not a requirement of the program. Usually they're course assignments.
entendi, perfeito.
Perfectly understood. Dr. Monica, would you like to say something? I see your hand raised. Please.
Muito obrigada, Manuel.
Thank you
Eu
so much,
gostaria
Manuel. I
de
would
fazer uma
like
pergunta.
to make a question.
Um minutinho que eu vou tirar aqui
Just a minute to shut down the... Can you hear me now? Yeah? Well, I would like to make a question to Professor Denise. Basically, I would like just to see the full process of advance that you had to take APN in the interprofessional relation. How have you dealt with the difficulties or the barriers or the contradiction between the professional categories to advance in this perspective? What strategies have you used, or how? That would be my first question. And after that, the topic would be, how do you advance towards regulation to converge this process of interaction into a regulation, which would enable you to advance? And I believe this is a challenge when you think in such a strategy, right? And my second question is, how have you been changing the basic formation curriculum for the nursing career, thinking that for the future, the full career must be strengthened? Today, the advanced practice concept that you increase the formation based on a specialization, but how will it be 10 years from now? Will it need it to be still a master or a doctor, or the career will be more important? Well, these would be my questions for now, Dr. Denise. Thank you so much, Manuel.
Okay. So the first one about interprofessional relationships, and so I'll just start with the elephant in the room. The biggest challenge relates to physicians, and over time we're seeing less physician resistance, and it does vary by province to province, and also in specialty areas. So I can say that the initial years to introduce the NP program, where we made the biggest gains is in areas where there were few physicians. So I think if you're going to start, think about the low-hanging fruit where you're going to have the least resistance. Don't start where it's going to be a 10-year battle. Start where there's a high need for where there are underserviced populations, where there's a shortage of physicians. They're not going to argue about putting NPs in those areas because they don't want to go there. And there are also populations that might benefit the most from nurse practitioner care because they're complex and they require a holistic approach, etc. So I would think about looking at areas where there are fewer physicians and therefore less resistance. That being said, it's important to engage physician groups all the way along as a stakeholder. They need to be at every table. It's important to listen to what their concerns are and address them. So for example, in Canada, one major concern early on from physicians was liability. That if they collaborate with an NP and the NP makes a mistake, that the physician is liable. Well, that was a myth because NPs had an autonomous practice, but there is some, in the early days, there was more supervision and collaboration required. But even still, nurse practitioners are autonomous. They're responsible for their own practice. The physicians are not responsible for NP practice. But one of the things that did help to alleviate that as a potential source of a barrier was to make sure that NPs had good liability insurance coverage. And it was actually increased, the tail coverage. So, even past when the NP had left a position was increased across Canada. So there's a national program for healthcare insurance coverage for nurses and NPs, and it was increased. And so you just eliminate an argument or a barrier. So the ones that you can eliminate, try and address them. So that was one example. The other one is, so you need to work with physician champions. So those who get what a nurse practitioner can bring to their team, to their program, to improve population health. So you need to be working with champions, have them at your table, but you also have to have the resistors at the table, hear what they say and try and address them. And so every step of the way, like the Canadian Medical Association, for example, has been a key stakeholder, and the provincial physician groups have been key stakeholders to bring them along. So,
Muito obrigado.
So regulation. Well, sometimes, regulation is a policy, and often policies lag behind practice. And so one of the ways we can push regulation is by pushing the boundaries of practice. So I would say, don't quote me on that, but in the early days before NP roles were formalized, nurses were working at the borders of their scope of practice and pushing those boundaries. And so, I'm kind of, you say, well, you do what you think is right, and then you ask for forgiveness, within some legal parameters. So I think continuing to push the boundaries and to demonstrate how innovating nursing roles and expanding their scope of practice can have an impact. We've seen that in the response to COVID-19, how maximizing the scope of practice of registered nurses and advanced practice nurses in countries that did that, they performed much better. They were able to address health system needs. And so we need to build on those experiences as examples. I think working with the regulators, they're another stakeholder that needs to be at every table, and educating them and bringing them along, and also learning from them about what the challenges or issues are. And national nursing associations need to be working with the regulators and governments to identify and tackle legislation that is a barrier to regulatory change. So often it means changing laws. And so that takes time. So I can say, back in the day, I was one of those clinical nurse specialists pushing the boundaries of practice. So an example I could give is, as an oncology clinical nurse specialist, I worked with 2 physician teams. I had a roster of 160 patients that I managed collaboratively with those physician teams, both in an inpatient and outpatient setting. And, we implemented different models of care. I had a clinical nurse specialist-led clinic, and how did we manage the regulatory issues? Well, my clinic ran physically alongside his. And when I needed a prescription, I would pass it to him and he would sign it. When I needed to order a diagnostic test, I would fill out the form and he would sign it. And, and we kept track of these kinds of things. And eventually over time, the light bulb goes on and people see this is what it could be. And these roles could be more efficient if they didn't have to get everything co-signed, etc., and that they've got the knowledge, skills, and expertise to do it. So sometimes you just need to do it, obviously within legal parameters, but you just need to do it. I think is one thing I could say. You need to be brave. You need to push those boundaries. Nurses need to support each other in doing that. Sometimes the biggest pushback I had as an advanced practice nurse was not necessarily from physicians, but from nurses. And so, also working with your nursing colleagues to help them understand what it is that you're doing and why your role is different, etc. So I think, those are things that can help to address the regulatory issues. The final question around the curriculum one, you're going to have to repeat that for me because I'm not sure I fully understood it.
Eu queria falar sobre a educação.
I would like to talk about education because advanced practice nursing has a clinical component which is really strong, but now it's associated currently to the formation process of the postgraduates, to the mastering or also to a doctoring. But we must have to consider the change since the beginning of the basic formation of the career to be the nursing as a so we don't have to take all those formation steps in a specialized way. How we can strengthen this profession?
I think I understand what you're saying. We struggled with that, I think, for a few years as CNS and NP roles were evolving. Even CNSs, they don't really fit anywhere in an education program. We don't have, we just have one or, I think I can only think of one CNS program in the country. Other programs have courses that are geared for CNSs, but it's not a program. So I think one thing that helped was a national initiative led by the Canadian Association of University Schools of Nursing to look at, what are the differences between a baccalaureate prepared nurse, a master's prepared nurse, and a PhD prepared nurse. And at the master's level, they also teased that out a little bit more. So we have master's prepared advanced practice nurses in clinical roles. And how do they differ from master's prepared nurses who are not in advanced practice roles, advanced practice nursing roles? They do function at an advanced level, but they're clinical educators or researchers or healthcare managers or administrators. And so there was a lot of work to kind of tease those things out as to, what should land there so that there were clear streams and differences. And so you could evolve over time. And we have masters and prepared CNSs and NPs, but we need more PhD prepared NPs and CNSs as well to be doing research and leading research in their areas of practice to build the science in those areas. So, you know, we do have PhD prepared advanced practice nurses, but of course it's fewer. And also the model. So going back to the issue around career paths of the clinician scientist. And, you know, I've straddled that role for the last 20 years as a CNS, a clinical nurse specialist in a cancer center, but also getting my PhD and doing research. And there are very few models for that in Canada. And, you know, and who pays you, who employs you, who pays you. And, you know, really that was something that I had to negotiate along the way, and have had to continue negotiating along the way about how I spend my time. You know, McMaster is now my formal employer. The Cancer Center is not my employer, and they don't pay my time. But for many years, they paid part of my salary for me to be at the Cancer Center and to be doing clinical practice and other nursing professional practice leadership initiatives. And I think academic clinical practice partnerships are an important thing to consider in that career laddering stream, because it brings academia together with the practice setting. You've got PhD prepared nurses, advanced practice nurses, working alongside a newly graduated NPs and CNSs, helping them with their practice, doing research, providing leadership within organizations. And it's a win-win because it connects the university to the practice setting, which you need for clinical placements. And also, it also creates opportunity for research. And for the organization, it provides them with a higher level of nursing leadership in the organization to promote the development of advanced practice nurses, as well as nursing research in other areas. So I would strongly recommend that as something to consider in that career laddering and how those roles can be funded.
Muito obrigado, professora Denise. Acho que
Thank you so much, Professor Denise. We have to advance to the closing of our session. We already exceeded 8 minutes from our schedule that we had, 1 hour and a half for this session. We have loads and lots of questions. We need a second meeting with you. We would be very happy to have this new opportunity to continue our discussion, debates, and conversations, because we have lots of questions also related to the role of the NP and the fixation of the professionals in remote areas. If we have policies to settle them in those areas, what are the incentives and differences in salaries, and also programs for to prepare the teachers, the tutors, who would prepare the nurses. This is also a huge concern that we have here in Brazil. How would we start this? Who will prepare those people?
Yeah.
And
so I'd be happy to do that. I'm happy to do a follow-up to answer any questions.
que bom.
That will be great, yes. And I would like, if possible, if you could leave us a final message to the Brazilian nursing, and that aims and dreams with this possibility of advanced roles, so we could think on our perspectives and the future pathway that we are going to take.
Yeah. Well, thank you for that opportunity. As I get closer to the end of my career than the beginning, I've been reflecting a lot on what my career has been like and the opportunity that presented to me ultimately to become an advanced practice nurse. And really the opportunities for registered nurses out there who are thinking about advanced practice nursing, the opportunities really are endless. And yes, it is a challenge sometimes to introduce these roles, but the rewards, both personally and also in terms of impact for patients, individual patients and their families, but also organizations and health systems, is tremendous. And so it's worth all of the effort to take the risk, to take the challenges, to think beyond the traditional boundaries of our scope of practice, and to expand those opportunities to really maximize the use of nurses. And I think the other thing too that's important about advanced practice nursing roles, while patients and improving patient health outcomes is the ultimate focus, the introduction of advanced practice nursing roles into health systems also elevates nursing practice overall, because advanced practice nurses support registered nurses and registered practical nurses at the bedside. They bring innovation and evidence-based practice to organizations. And so overall, the introduction of the role strengthens nursing across the board, not just one level of nursing, to improve patient health outcomes and impact, and also to increase access to care. So as you can see, I'm a little bit passionate about advanced practice nursing, and I really look forward to seeing how this unfolds in Brazil. I know there's already been a lot of work where people have been pioneering the roles, and I salute them. And I'm really looking forward to seeing what happens over the next few years as you continue down this important path.
Muitíssimo obrigado.
Thank you so much, Professor. Thank you so much to count with your presence, with your support. And it's good to know that you will be supporting us, and you will also be part of this historical moment for us, for the Brazilian nursing, that will be opening and thinking and reflecting on the advanced professions. And I will always be using your sentence. Let's go beyond the borders of practice. Well, I will not quote you, I will not say that you said, but I will remember this forever, because that's what we really need to do. If that's not the way, it's not going to work. So I certainly now, I pass the word now back to Monica Duranz from PAHO. Thank you very much. Thank you very much, Manuel. Thank you very much, Dr. Denise. It was a huge pleasure and a wonderful presentation. And before we close, I, first of all, would like to thank for the presence of all the participants on the several platforms that we had, the several channels, Portal of Innovation, Cofen YouTube, Confen's Facebook page, and the nursing school on YouTube. So we had a very active group, and we're going to have lots of information and knowledge to advance in our discussions. But before closing, I would like to reinforce to everyone the invitation so you can access the portal of IPS Redes to access the second public tender for the Innovation Lab in Nursing. The registrations are open until the 31st of October 2021. It will be a great satisfaction to receive the several works, and in the diversity that we have in our country, we are sure that we have a lot of interesting work that will be presented and put into evidence in this proposal for the second innovative lab in nursing. Thank you so much. I reinforce everybody's participation, and we will be waiting for you for our next meeting that will be on October 15th, next Friday at 2 p.m. We are going to have the participation of Professor Dr. Elena Gonzalo from the Andalusia School of Public Health in Spain. Having said that, I only have to thank everyone's participation and close officially this meeting. Thank you, everyone.
Muito obrigada a todos. Precisamos dos documentos.
Thank you very much, everyone.